Yeah, okay. So get a little diversion here with the weeping Pablo Picasso, who all of his paintings always to me look like somebody's out of their mind. But we want to kind of hone in on some of the elements of dementia diagnosis. I think Dr. Anderson and Dr. Hines' comments were very appropriate and astute. So we appreciate their feedback on and their presentations there. So there's probably more than 13 types of dementia, but these are the ones that we know and talk about. The reference to the and some are quite rare. So as Dr. Anderson was saying, the prion disease of the Creutzfeldt-Jakob disease has 350 cases in the United States annually, and they're very rapidly progressive, like Lewy body dementia. Basically, the deterioration occurs within a 1 year to 2 year period of time, as opposed to Alzheimer's, which is a more lingering progressive disease over a 10 to 12 year period. One of my, I don't know, not a favorite diagnosis, but one that always amazes me is this dementia called fatal familial insomnia. And I guess I thought I had that when I was in college because I spent a lot of nights up studying. So as we try to make the diagnosis of dementia, we need to look at memory concerns. If an individual uses lists a lot as a compensatory mechanism, that's good. Ronald Reagan had word searching in his latter term. I don't know if you ever watched any of his speeches, but I was a geriatric fellow at the time, and I said, my gosh, he has Alzheimer's disease. And that was because he kept looking for words. Getting lost is also symptomatic of dementias. Object misplacement or misidentification of objects can be associated with Parkinson's dementia. And then, as mentioned earlier by Dr. Hines, functional impairments are quite a telling element in memory decline or in dementia. Alcohol use, particularly excessive alcohol use, is a predictor of dementia. Somebody asked that as a question. Alcohol is toxic. I call it a 2-for-1 rule. And you say 2 for 1 what? It sounds like a sales, in Menards or something. 2 for 1 means that one drink of alcohol in most older adults equals 2 alcohol drinks. And I had my father-in-law, when he was alive, was told by his doctor with his Parkinson's that he could no longer have 2 martinis. He had to have 1 martini. And so he thought he was going to be very clever. And what he did is he, instead of using the 80 proof vodka, he went to 150 proof vodka. So he got his 2 martinis into 1. So that was pretty clever of him. The other issue that comes up are gait problems and falls, which are people with memory loss have up to a 2-fold increase in fall rates. I think we recognize behavioral changes and personality changes. Turns out depression is the most frequent. And so I saw somebody put in that their spouse was treated with sertraline or an antidepressant. Probably more than 60% is my understanding of patients with early onset of dementia get treated with antidepressants. Other things to watch for are tremors or twitches. The medical term for that is myoclonus. You see that twitching. Those are more ominous and for more rapidly progressive diseases. And then just overall withdrawal, so that kind of apathy. So these are, some of the major things that we would want to look for clinically in doing our survey. In terms of a clinical exam, things that I look for are upward gaze paralysis. Sometimes that's associated with progressive supranuclear palsy. It's a type of Parkinsonism. Frontal release signs, so that's where you touch the lips and they pucker up. Or if you tap the front of the forehead, you can get, you're supposed to stop blinking, and if the person continues to blink with the tapping, that would be a frontal release sign. I also look for cogwheeling because I'm concerned about midbrain diseases. Also looking for tremors and fasciculations, lack of coordination. Also, as it turns out, I look for gait speed, and anything under what we measure 1 meter per second indicates a higher risk for dementing illnesses. This has actually become a controversy in my household because I tend to walk very fast, and my wife is always annoyed that I'm walking so fast in front of her, and she doesn't keep up. And she says, "Why do you walk so fast?" I said, "Well, if you walk slow, it may mean that you have Alzheimer's." So she's pedaling away to keep up with me. Looking at vibratory sense is important because sometimes you can get vitamin deficiencies that might be revealed, or alternatively, if you get numbness or paresthesias in both the feet and hands, that can be indicative of heavy metal toxicity. Another clinical story, I had a patient who actually described paresthesias of both his hands and his feet, and we got heavy metal testing in his urine, and sure enough, he had arsenic elevation and mercury. And I said, I told him, I said, well, you know, good news, we figured what's going on. And I said, the bad news, the fellow was an avid walleye fisherman. I said, yeah, you've now been enrolled in the catch and release program. So he couldn't eat his walleye that he was catching every day. The other part is of testing is cognitive testing. And we actually are advocating as part of our age-friendly healthcare programming is to have primary care providers do mini-cog testing with each, or some memory testing with clinical encounters with all 65 and older individuals. The mini-cog test is what we used for quick screening. It's a 3-object recall. So Apple flag car, can you remember that? After you draw the clock, and you can see some clocks here. It's supposed to be 10 after 11, and you can see how people kind of mess that up. So the scoring for the mini-cog is that you've got only 1 or 2 recalls plus an abnormal clock. Basically would be a cognitively impaired individual that needs to be further tested. I tend to use a score of 3 out of 5 as a potential means of looking for further investigations for memory disorders, but the cutoff is 2 out of 5 here in this particular test. There's another test that so if somebody doesn't want to do any type of memory testing, word recall, you can do what's called verbal or category fluency. So just ask them to name as many animals as they can name. And if they don't name 12 or more animals within 60 seconds or 1 minute, then there's some concern for dementing illnesses. This is called the SLUMS test. It's kind of an odd name, but it represents the St. Louis University Mental Status Test. I kind of like it because number 11 here has a story about Chicago, where I spent most of my medical career before I moved up to North Dakota, happily, becoming a North Dakotan here, adopted one at that. This test is very similar to the other types of tests, but it's a 30-point score. And it's actually very good for detecting minimum cognitive impairment. We mentioned some of the blood and other tests, and those include, generally we get a survey looking for electrolyte disorders, anemia, B12, and if you're diabetic, folate deficiencies, thyroid, and then the infectious and inflammatory tests. Ordering the lipid protein test called ApoE4 is of concern in a younger patient who might have what we call familial rather than the other version called sporadic Alzheimer's disease. Talked a little bit about brain imaging earlier, and there's a variety of options. So why we get a head CT or a plain CT, you can see some examples here. On the left, you can see a pretty much golf ball size tumor in the brain. This is actually on the right side. You're always looking from the feet up. Here in the middle is a case of normal pressure hydrocephalus. We often call these, a mnemonic for remembering this is wild, wet, and wobbly. So these are people that are, have a little agitation, get a little hyper. They're incontinent of urine, and they're wobbly. They fall and have a gait disturbance. Usually it's a wide-based gait. And then you can see here on the final slide, or a picture here, a CAT scan with a subdural hematoma. So that's that darker region with the white line around it. MRI, so some of the Alzheimer's centers are using serial MRI scans, particularly for minimum cognitive impairment. You can see some of the atrophy that occurs here in this Alzheimer's disease slide here. So there's a lot of atrophy compared to the upper slide, which is a healthy, normal control. And that you get what people look at as progressive hippocampal volume loss. And there was an interesting research study out of Europe that showed that people that were on a Mediterranean diet over a 5-year period had preservation of their hippocampal volume, whereas people who were omnivores, heavy meat eaters, had a 10% decline in their hippocampal volume. So if there's any rationale behind becoming a vegetarian, that's my strongest case for doing so. These are PET scans, and so these are metabolic scans, and you can see that there's a difference in the overall redness. These are tracers that track usually glucose, so there's decreased perfusion and metabolism in the Alzheimer's brain. The mild cognitive impairment is perhaps closer to the normal brain, but it does show some subtle differences, a little bit beyond my pay grade to really interpret these, but we rely upon our neurology colleagues to inform us of what they see. There's what's called a SPECT scan, and they can actually now develop a 3-dimensional scan of this. And SPECT scans are, to my understanding, best used for frontal temporal dementia. And you can see sort of on the right side here, a frontal temporal dementia where there's a lot of Swiss cheese evidence, in the scan. We mentioned neuropsych testing, which is, I think, the standby. The neuropsych testing is probably more valuable for people that are college educated or may not be college educated but have a higher IQ. Brain biopsies are for those rapidly progressive diseases and for people that have twitching. EEGs, sometimes temporal lobe seizures can present as intermittent zone outs. People say they just sit there and stare into space. I think they're having dementia, and when in fact it may be seizures. So just to summarize, we know clinically that dementia is not just memory loss, but it's loss of executive function. There's a progressive history of functional decline and behavioral changes. And I have to say that one of my comparisons between my clinical practice as a geriatric doctor in Chicago versus up in Fargo, or down in Fargo from my point of view, because I'm living in Grand Forks, is that my clinical impression is that here in North Dakota, individuals that do have dementing illnesses tend to function at a higher level than I ever saw in urban Chicago. Now, I don't know if that holds up. I haven't done any research on it, but again, usually what happens, and I believe Dr. Hines kind of emphasized that the memory loss and the functional decline go hand in hand. But again, here I think there's a disconnect, and maybe at some point I'll get enough energy to do the research to figure that out. The other point in evaluation of dementia is looking for physical exam signs in addition to a good, strong history. and then always, in terms of the diagnostic workup, to look for reversible causes. And I just want to compliment our other speakers about identifying the brain to prevent Alzheimer's by the importance of good blood pressure control, cognitive engagement, some mind games, socialization, and then finally exercise. So those are the three main things. Maybe next year or the year after, they'll include nutrition as part of the interventions to prevent Alzheimer's.